interesting case that we're going to look at in terms of the didactic. A lot of questions were raised from the last week's presentation, and we didn't manage to answer some of the questions that were being presented on the chat. And so I hope today's presentation will be able to answer that. But we want to make special welcome to Mtendere Mission Hospital. They are joining us for the very first time. Mtendere, why don't you wave to us so that we see you time, maybe they could raise their hand and just say hello to us. Okay, so if there's none,
Hello.
Oh, Sialondwe Derek, that's Livingston. Welcome.
Hello.
We're happy to have you here. Thank you so much.
Hello.
And then we also have Bosco.
Yes, we are in Pasha. Monze DHO.
All right, welcome Monze DHO.
Thank you. Thank you.
Movita Sikuka, where are you?
I'm in Yuka.
Okay, you're welcome.
Western Province.
All right, you're welcome.
Thank you.
So, thank you so much. So this afternoon we will have a presentation, a didactic being presented to us by an expert, and there's Dr. Mwiya sitting right next to me. Dr. Mwiya, why don't you say hello?
Hello.
And then we also have experts with us in our presence. We've got Dr. Mpeta, Dr. Sivile, and the usual suspect, Dr. Sombo. And we also have Dr. Thomas here in our presence. Say hello, Dr. Thomas.
Hi.
Okay. And so we have our sister in charge as well over here.
Good afternoon.
So we also have another visiting, one of our colleagues visiting, Sombo.
She's from University of Maryland. She's with the IGT.
You're welcome. Then we've got somebody here at the back.
One of our registered nurses.
Okay. So we'll quickly go into a recap of the things that were discussed last week. And then we're going to ask our assistant in charge, Madam Mwamba, just to give us some of the things that were discussed yesterday.
Good afternoon, everyone. My name is Evelyn Mwamba. A brief recap of our last week's session. In our session, our topic was viral load monitoring pregnant and breastfeeding women. Viral load is the presence of detectable HIV viruses in the blood. Viral load testing and management of high viral load is the necessary activity to achieve the 90-90 goal in the management of pregnant and breastfeeding women. We discussed that all pregnant and breastfeeding women should have a viral load done every 6 months. All women on earth should have a viral load 1 week to 4 weeks before delivery to help categorize the risk status of the child. For newly initiated at antenatal, we should book them for 6 months. We should book them for 6 months viral load and 1 week to 4 weeks before delivery. We also discussed that all pregnant and breastfeeding women with unsuppressed viral load should be entered into high viral load register so that they are followed up according to our Zambian guidelines. We repeat the viral load after 3 months. Pregnant and breastfeeding women with unsuppressed viral load with good adherence should be switched to second line. Thank you.
So thank you so much, Sister Evelyn Mwamba. This time we will now invite our expert, Dr. Mwiya, to begin his presentation. And so we are going to just share the presentation.
Just stop the share.
Okay.
So, Dr. Mwiya, you can introduce yourself.
Again.
What you do here at
So, Dr. Mwiya.
Okay. So, so my name is Dr. Mwiya, like my colleagues have said. I'm based here at the Pediatric Center of Excellence. I'm a pediatrician. So for all those people that have made a call on 7040 related to issues on pediatrics, female voice answers, that's me. I work with females only. So if you hear male voice, then you are talking to me, the person you are seeing today, if you've never met in real life. Okay, so today we are looking at management of HIV-exposed infants, and our objectives are, we're going to define what an HIV-exposed infant is, and then two, management of the HIV-exposed infant, who can be classified as low or high risk, depending on the viral load of the mother and a few other criteria before at delivery. And then also we're looking at management of HIV-exposed infant in complicated scenarios. And the third objective is how to prepare zidovudine, lamivudine, which is AZT suspension. These are dispensable tablets, so we're trying to demonstrate or explain on how to prepare these dispensable tablets into a suspension for use in these HIE infants. So we're going to our polling questions. You have to read.
I'll pick it up.
Okay.
So let me just pick up on the polling questions. And so at this stage, we have 3 polling questions, and then we invite you to just take part in responding, giving the appropriate answers. So there is a first question, and I'll read. Which of the following statement is true? Which of the following statements is true? An infant born to a mother who initiates ART intrapartum should receive ARV prophylaxis for 6 weeks. B, prophylactic ARVs, that is AZT, 3TC, and NVP, should be given to a baby whose mother refuses ART until baby's confirmed final outcome is after complete cessation of breastfeeding. C, an HIV-exposed infant is one born from an HIV-infected mother but has HIV infection. So we would like to see some polling coming in now at this stage. We have a minute and 15 minutes in which to respond to this polling question. So far, we're doing fairly well. We have about 18 people that have polled in. But we can do better. We're about 88 participants. So let's bring in the answers. So which of the following statements is true? An infant born to a mother who initiates ART intrapartum should receive ARV prophylaxis for 6 weeks. Or B, prophylactic ARVs should be given to a baby whose mother refuses ART until the baby's confirmed final outcome is HIV negative after complete cessation. Or an HIV-exposed infant is one born from an HIV-infected mother but has HIV infection. So we've had quite some minutes So we can end the polling just here. So I'll move on to the next one. Baisha. So this is how we polled and this is how we fared. We'll move on to the next question. The following is true concerning a baby whose mother's viral load is greater than 1,000 copies per mil. That is after 12 weeks of infant prophylaxis and still breastfeeding. The baby is classified as high risk. Restart prophylactic ARVs until the mother is suppressed. Start prophylactic ARVs until after complete cessation of breastfeeding, or all of the above. The following is true concerning a baby whose mother's viral load is greater than 1,000 copies per mil after 12 weeks of infant prophylaxis and still breastfeeding. The baby is classified as high risk. Restart prophylactic ARVs until the mother is suppressed. Restart prophylactic ARVs until after complete cessation of breastfeeding, or of the above. We can poll. 8 have so far polled. After we exit the polling. Okay. I'll give you a bit more time. Maybe about 5 seconds. Okay, so we'll end the polling just here. And so that's how we fared in this polling. About half the participants managed to make a choice. So the next question. What should be done if a 12 weeks old breastfeeding baby comes to the clinic who has not taken prophylactic ARVs? Mothers is not yet on ART. What should be done if a 12 weeks old breastfeeding baby comes to the clinic who has not taken prophylactic ARVs? Mother is not yet on ART. A. Initiate lifelong ART in the mother and prophylactic ARVs in the baby and give for 12 weeks. Initiate lifelong ART in the mother and prophylactic ARVs in the baby, prophylactic ARVs, and only give for 6 weeks. There is no need to initiate prophylactic ARVs in this child. D, none of the above.
Can we not change the one in the background also?
How do I do that?
Just the slide, changing the slide.
It's not changing. Oh, now it is.
Yeah. That's what the HIV exposed. What should be done?
So what should be done if a 12 weeks old breastfeeding baby comes to the clinic who has not taken prophylactic ARVs?
Baby.
Sorry. It's HIV exposed baby.
Yes.
Sorry, maybe there may be an omission on this question. So what should be done for an HIV exposed 12 weeks old breastfeeding baby who comes to the clinic who has not taken prophylactic ARVs and the mother is not yet on ART? Initiate lifelong ART in the mother and prophylactic ARVs in the baby and give for 12 weeks. Initiate lifelong ART in the mother and prophylactic ARVs in the baby, prophylactic, and only give for 6 weeks. There is no need to initiate prophylactic ARVs in this child. This is a bit difficult. B.
Okay.
It's okay.
just a period of time.
Okay. So we have about 20 seconds to answer this one.
This one, maybe.
Okay. So we can end the poll here for now. So this is how we've performed. At this particular time, I'm going to hand you back over to the expert that is here with us today, and so that we can continue with the didactic presentation. Dr. Mwiya.
Okay, thank you very much, Dr. Ziambo. So we'd like to define what an HIV-exposed infant is. This is an infant born or a baby born to a mother who is HIV infected, but the child or the infant has no HIV infection. That's what we mean by somebody who's HIV exposed. So in terms of care of these HIV exposed infants, all HIV exposed infants should receive postpartum zidovudine, lamivudine, and nevirapine, which is AZT3 nevirapine, as prophylaxis to reduce the risk of mother-child transmission of HIV. Okay, now this depends on the mother's viral load 4 weeks before delivery, or 1 to 4 weeks before delivery. When the baby is born, is classified as at high risk or low risk. Low risk means that the the mother's viral load less than 1,000 copies per mil. And then that one who's classified as high risk, the mother's viral load is more than 1,000 copies per mil. However, I also add a few definitions to what we mean by low risk, high risk. So other things added on, a low risk infant is the one born to an HIV positive mother on CRT or combined antiretroviral therapy for more than 12 weeks at the time of delivery, or HIV positive mother with viral load less than 1,000 copies within 1 to 4 weeks before delivery. Such an infant should receive prophylaxis, which is AZT3 TCNVP for 6 weeks. But the most important thing here is the viral load, which is supposed to be less than 1,000 copies per mil. Okay, so a high-risk infant is defined as that one born to a mother who received ART or CRT less than 12 weeks by the time of delivery, and the viral load is more than 1,000 copies within the first 4 weeks or 1 to 4 weeks before delivery. Okay, or the mother initiates ART antepartum 12 weeks before delivery, similar to the first point, or if the mother initiates ART intrapartum or postpartum, such a baby is defined as high risk. Or the mother has got established HIV infection not on CRT. Such an infant should receive ART or prophylaxis for 12 weeks. Okay, so we also have certain complicated cases, and some of these have been asked on this fora. For example, an infant born to a mother who's known to be HIV infected, but refuses to be on CRT. So what do we do to this baby? The mother has refused. First of all, what is important is to continue counseling the mother so that you can start ART for her own healthy. But for the baby, what we do is that we give prophylaxis to this baby. If the mother continues to refuse, the baby will be given this prophylaxis AZT3 until the time the baby stops breastfeeding, 7 days after cessation of breastfeeding. However, because of the side effects of zidovudine, we encourage that people should continue monitoring for anemia and neutropenia. If severe anemia and neutropenia develop, then you have to stop zidovudine and lamivudine and continue nevirapine, which will go on until 7 days after cessation of breastfeeding. This one, we got it from our previous guidelines where we used to give nevirapine to babies throughout the entire breastfeeding. At the time, we were giving mothers who are not eligible for ART. Also, what to note here is that cotramoxaz, which we give from the 6 weeks of age, can also have similar side effects with zidovudine. Okay, another complicated case which has been asked before on this fora is, for example, a mother's viral load is more than 1,000 copies after the child had completed the 12 weeks of prophylaxis, but still breastfeeding. Such an infant, we still classify them as high risk. They are still in danger of being infected. So at this stage, depending on the age, we will do age-appropriate HIV test. If they are below 9 months, the first test we go for is a NAT. After 9 months, we start with a rapid test or serological test. If any of the serological test is negative, then we start the prophylaxis. But if it's positive, then we go for a NAT. While waiting for NAT, we can give prophylaxis. In this case, we are starting AZT3TC, NVP, until the mother is well suppressed. We hope here that the physicians, adult physicians looking after this mother, will put the mother on efficacious regimens which are going to have this mother suppress or have her to get suppressed before, or not to continue being unsuppressed for a long time, so that we don't continue giving this baby the prophylaxis for a longer time. Okay? So the mother, until the mother is well suppressed or after complete cessation of breastfeeding. If you're infected, you should stop the prophylaxis. If you're infected, sorry, you should stop prophylaxis and start CRT. Okay, another complicated case. This is a baby born to mother with antiretroviral drug resistance virus. Okay, so far there's no evidence that suggests that prophylaxis regimens customized based on presence of maternal drug resistance are more effective than standard neonatal prophylaxis regimens. Actually, some studies have suggested that the drug resistance virus has a decreased replicative capacity, what we call reduced viral fitness, meaning that it doesn't replicate or reproduce as much as a wild-type virus. In the same vein, the transmissibility or the ability to transmit to the baby also is reduced, okay? Such that the virus which is most likely to be transmitted to the baby is a wild-type virus. And therefore, standard AZT3TC still remains active. If we went back to our guidelines, our first-line regimen for pregnant women is TLE, which is tenofovir, lamivudine, and efavirenz. If they fail this regimen, Dr. Sombo, guide me. I think the second line is AZT3TC opinaba. So if such a mother failed the TLE, which is tenofovir, lamivudine, and efavirenz, there's still room for use of zidovudine. So in this case, the zidovudine of put as prophylaxis for the baby will still be active. So that is another rationale. If somebody is not clear about this, you can still consult us on 7040 or discuss. Okay. One of our objectives was how to prepare the AZT3T dispensable tablets. What was in the guidelines, what is in the guideline was to put 10 tablets in 60 ml of water. This has led to a lot of problems, as I will show you in the next slide on dosage. So the best we can do is, the problem, when if I leave that, has been, the solution has been, the shelf life is not something that can stay longer on the shelf life is short, such that the complaints I've got from the people is that the drugs were giving an offensive smell within after a few days. Therefore, the best that one can do is to mix this tablet in 6 ml of water. It will give you the same amount of drug per meal. If we say 10 tablets in 60 ml, it will give you 10 milligrams of AZT and 5 milligrams of lamivudine per meal, similar to the 6 meals. So this is, I think, is better because it will be consumed in a short time before the drug goes bad. The other formulation you have is nevirapine syrup. Next slide. So these are the dosages. I will take you to the zidovudine because the nevirapine comes already as a syrup. So it's got a longer shelf life and it's just going straight. But the ones who are constituting with plain water, it will give you 10 milligrams of zidovudine, 5 milligrams of lamivudine per meal. So you can see, for example, a baby weighing 2 kgs to 2.499, they will get 1 meal twice a day, meaning that if there are 6 meals, it will be consumed within a week. So like 2 meals per day, 2 meals per day. So in 3 days, this drug is consumed. So the chances of it rotting or going bad are minimized. So I think this is the best way to go. So this is just showing how much to give to what age, to the weight and the age group. The other one is the one where the infant is weighing less than 2 kgs and more than 35 kg for 35 weeks. There's also a dose there, 2 milligrams per kg daily. And for the zidovudine, lamivudine, I've put the dose of zidovudine 4 milligrams per kg twice a day. Because once you have calculated the dose of zidovudine, the lamivudine will fall in place, since this is a fixed dose combination. Then those who are premature, this one you have to call us so that we discuss on how best we can manage the child, because sometimes the doses range depending on the gestation period. Okay, so as part of care for these patients who are HIV exposed, we should follow the national guidelines. Sorry, there's a typo. We said mother be advised to breastfeed accordingly. So here, what we mean is that mothers are advised to breastfeed exclusively for 6 weeks or 6 months, and then add complementary feeds accordingly. And then they will go on breastfeeding until the child is used to eating other feeds, the normal way to do it. Another one, which obviously is a bit controversial with some people, there are people who feel that every woman will breastfeed. But we have others who say, no, me, I don't want. So if that does happen, we should help the mother to ensure that AFAS has been met affordable, feasible, acceptable, sustainable, and safe, meaning that they're going to give other feeds, so you should support them. But otherwise, by all standards, the best is breastfeeding. But if it does happen that they don't want, support whatever mode of feeding that they have chosen. But ours is breastfeeding. Then when I said HIV screening schedule to be followed, meaning that this baby should be tested at birth, 6 weeks, 6 months, 9 months, 12 months, 18 months, and 24 months. So for those below 9 months, we use NAT. Above 9 months, we start using serology. If it's found to be reactive, then we do, or positive, then we do NAT to confirm infection. Or under 5 vaccines should be given. This we should follow the national guidelines where all the vaccines are given. The only time we may not give a vaccine if a child presents with signs of HIV, then you may not give BCG. But this was an exposed child or infant, so they have to be given all the vaccines. Let's not forget monitoring growth and development. Very critical for us to know that the child is growing well. Then cotrimoxazole should start at the age of 6 weeks of age. Okay, some of the key points. All HIV-exposed infants should receive AZT, 3TC, and VP. Depending on the classification, we put them at birth for 6 weeks or for 12 weeks. And also, depending on the circumstances in which one finds themselves in terms of complicated cases, appropriate action should be taken. The second point is that zidovudine lamivudine tablet should be dissolved in 6 ml of cool, clean water. Okay, very important, cool, clean water. Okay, so that the amount of fluid that you have made is not going to be to go on the shelf for a long time. I've given an example for the one weighing 2 kgs to 2.499. They will consume 2 meals per day. So within 3 days, the solution is finished. And breastfeeding infant whose mother gets infected postpartum should receive AZT 3TC prophylaxis for 12 weeks. This is to allow the mother to suppress. Okay, again, it all depends on how our colleagues, what kind of regimens they'll put the mother to ensure that she suppresses quickly. With a more new advanced DTG that was on the scene, which will be able to have someone suppress within a short period of time, I think that will be the best for us who look after the children, because then we know that our children won't have to consume these prophylactic drugs for a longer time. The fourth point is that prophylactic ARV should be initiated in the baby who is breastfeeding from a mother whose viral load becomes more than 1,000 copies per meal. Okay, this is the baby whose mother was suppressed or was on prophylaxis. When you do a viral load, suddenly the viral load is more than 1,000 copies. While they are figuring out on what to do with the mother, we should really initiate prophylaxis. Otherwise, chances of transmission becomes high. Baby born to non-HIV positive mother who refuses CRT should receive prophylactic CRT until confirmed final outcome negative after complete cessation of breastfeeding. In a nutshell, this one should be given prophylaxis until 7 days post-cessation breastfeeding. But please, here we have to monitor, if they have to born ICT3TC for a long time, we have to monitor for anemia and neutropenia. Thank you very much. So those are my names, and that's a contact number. But don't call me at 02, and my email address.
Yeah. Thank you so much. Thank you so much. Thank you so much, Dr. Mwiya. We appreciate this wonderful presentation. I believe it has responded to a lot of our questions that were asked in our last session. And they were quite concise and very clear, not confusing, not ambiguous at all. So what we're going to do now is we're going to invite for some questions from the folks before we bring in some comments here from our experts that are in the house today. So we will invite all those that would like to make some comments, questions. This is your time now. So do we have any questions from the folks?
You can get a comment. Maybe Patrick was online. Patrick Kabula. There's a comment.
Oh.
Patrick.
So I'll invite Matero if they've got any comments they would like to make on the presentation that has been made so far. Patrick, are you there?
Yeah. Yes, Doc. So the comment is on the DTG in women of childbearing age. It's been mentioned that to avoid the HIV-exposed infant to be on a longer time on the prophylaxis, we can give the more efficacious regimen to the mother. So are we able now? I mean, are we allowed to give women of childbearing age, especially those that are HIV, are pregnant, DTG-based regimen? So that's what the fellow participant here at the spoke are asking. Is it safe? So they are still asking that in pregnancy.
So the question is, sorry, now I've gotten a bit mixed up. Is it in pregnancy or in the breastfeeding woman?
In pregnancy.
So could you just run over your question one more time?
Childbearing. So the question is DTG safe in pregnant women?
All right, so I'll ask one of our experts here.
Before they come in.
Yeah.
So when I gave an example of DTG, I was just saying the more efficacious regimens, for example, DTG, but that depends on our adult physician colleagues. It's a good question though. Dr. Seville?
Okay. Good afternoon. Yeah, so I think the straightforward answer is yes. Obviously, we had a presentation some time back on this subject. The studies don't conclusively say that it's safe. There might be a minimal risk, but the guidelines are clear from the WHO and ourselves that DTG is a first-line drug, even in childbearing age. I'm sure that's what you wanted to say. Women of childbearing potential. So especially in this circumstance where the gains are clearly more than the risks. So we would recommend it.
Thank you so much, Dr. Seville. I've got a hand. Dr. Bosco, would you like to make a comment as well? You can unmute yourself. In the meantime, I've noticed that half of our participants don't have cameras on. We're not able to see you. We'll appreciate if you could turn on your camera so that we can see you as well. Are you able to say something, Dr. Bosco?
Yes, I've unmuted myself.
Please go ahead.
I'm glad for the question on the DTG safety, and I'm glad the way Dr. Sibile have answered it. Our guideline is very clear on page, on our, hello?
Yes.
Go ahead.
Yes, if you go on page 29, it is very clear that breastfeeding, pregnant women, adult, our first option, it is actually DTG. So, and WHO just confirmed what is in our guideline. And I take this advantage also to leave one of my colleagues, I'm in Pasha right now, Pasha Hospital. There's a colleague who have a question, maybe you can ask that question on the NAT at birth, maybe at later stage or now, with your permission.
Please go ahead and ask the question. It's welcome.
Good afternoon, everyone. My name is Margaret. I'm with Dr. Bosco in Mpansha. And
yes,
we want to find out from UTH, what is the experience concerning NAT testing at birth?
This is because we have two experiences, one in UTH, where a woman delivered last week, nurses could not do the NAT at birth there. So we are wondering if in UTH, a woman delivered in UTH cannot be given NAT there. So that's our question. Thank you.
Okay. So, Dr. Bosco, when we say NAT, we at the moment, NAT means nucleic acid test. So what we are doing, because NAT will detect both DNA and RNA. So what we are doing is the DNA PCR, which still qualifies to be called NAT.
Yes.
We don't have the point of care machines which NAT as per se, which detects both RNA and DNA, are not yet available. Like on UTH, we still continue using DNA PCR. That's our experience. So I'm not sure in what context, how, I mean, you really wanted to know in terms of NAT.
No, the context is the test, the DNA PCR at birth, it is not being done in several places. And we have evidence, even last week we called, yesterday, a woman delivered in UTH, they didn't do the test at birth. So we are worried. That's why we are asking the experience, are they collecting DNA PCR in UTH there? Because we have evidence, we can call you after the meeting.
No, I think they do. Maybe there's just, I'm not sure about that one, but otherwise the information we have is that they're supposed to do NAT at birth. Because we have a clinic where they are followed up actually, all those that deliver in UTH, unless they opt to go away to another facility. Anyway, if there was such a child, then we'll make a follow-up to ensure that birth testing is followed as in our guidelines. Thank you very much for the observation.
Thank you.
Thank you so much. We'll allow for a comment, one more comment from HNP in Livingston, and then afterwards we will move to the hub. Maybe the hub has also got some comments. Then we'll move on to the pause. Then I will ask Matero, Jude, if you're ready, please get ready, prepare your presentation because you're coming on next. So Livingston first.
Good afternoon.
Could you please speak up?
Good afternoon.
We can hear you.
Okay, I'm Stella from Livingston School of Nursing. Just wanted a clarification concerning AZT 3TC for the infants. It was mentioned to say if there's anemia or neutropenia, we discontinue, then we just keep the baby or the infant on NVP. So just wanted a clarification on that. Do we just give the baby on NVP or we can substitute?
Okay, so for prophylaxis, NVP is sufficient or not sufficient enough, but it still works well. We did that before. In our previous guidelines, 2014, we were using NVP for both those whose mothers were on ARVs and those who are not. And we had some very good results. So it's based on that we are getting that inference. that if they develop, otherwise we have no alternative when it comes to prophylaxis. These are the 3 drugs that are used for prophylaxis. So the only other one which can be on its own is nevirapine. And so far anyway, because the whole idea here is to make sure that the mother is worked on. The baby is a product of the problem of the mother, which is who is being mismanaged by ourselves. So if we can manage the mother well, then the baby won't be on this prophylaxis for a long time. So the cardinal thing and the most important thing is to make sure that the mother is put on efficacious regimen so that she's well suppressed as quickly as possible. So this is just an interim measure while we are waiting for the mother to be suppressed. Okay, we said that if the mother refuses, but let's try by all means to convince this mother with our good counseling. But anyway, it's true, we can put the baby on nevirapine because of no choice. Otherwise, the baby can die of anemia.
So I've noticed that on the chat, we've got some hands that have been raised, but we have limited time, but I'm going to allow Professor Lloyd Mlenga just to come in and make a comment.
Hi.
Hello.
Thanks for the presentation, Dr. Mwiya and Dr. Koze. Thanks for moderating the session. I wanted to say that I think what Dr. Bosco was experiencing in Mpasha where they are, it's just maybe a woman who fell through. Otherwise, the birth testing is done for the infants, but there may be some women who fall through. We have not, of course, expanded to all the facilities as Dr. Mwiya had said, but we are expanding this service. It's unfortunate that that woman fell through.
Thank you so much for your comment, Professor Lloyd. I know we've got Howard Mushisha also wants to make a comment. Can you make it very quickly? Okay, so we'll move on to the hub. We had some comments in the hub that people wanted to come in and make a comment. Quickly. Yes. And I hope, Terry, you're ready with your slides so that you can begin to share after we go through the poll.
My comment was in line with the people in Pasha where they wanted an experience with UTH. So at UTH, like at Adult Center of Excellence, that's where there's the PMTCT program. So women who deliver here, the PCRs are done on the wards, labor ward. Then at least most of them, they have results within a week and the babies are initiated on prophylaxis immediately. Mm.
All right, thank you for that comment. So we'll move on to the pause so that we can just go through the answers that were shared. Okay. What? It's not been shared. Okay.
Can you share from the screen? I don't
can share from me.
But you can start reading because you can. That's not the. It's okay.
Okay, so we'll start from question 1. Sorry, that's the wrong poll. So question 1, which of the following statements is true? I'm sure now things might be a bit better after that didactic presentation has been given. An infant born to a mother who initiates ART intrapartum should receive ARV prophylaxis for 6 weeks. Prophylactic ARVs should be given to a baby whose mother refuses ART until baby's confirmed final outcome is HIV negative after complete cessation of breastfeeding. An HIV-exposed infant is one born from HIV-infected mother but has HIV infection. Which of the following statement is true? following the discussion, the presentation that has been made, what do we think is the correct response to this poll? We have a few seconds. I'm expecting more people to respond now since we have gone through the didactic. So we should have more people to respond. And it should be in a shorter time. So we're going to end the pause here. And so this is the result again. What we see is that the correct answer is B. So, Dr. Mwiya, why is the answer B in this case?
Okay. Oh, okay. So this is the mother. So this is the question.
Which one's best? Question 1. So which of the following statement is true? Prophylactic ARVs should be given to a baby whose mother refuses ART until baby's confirmed final outcome is HIV negative after complete cessation of breastfeeding.
Okay, so the correct answer is B, because A, an infant born to mother with ART during intrapartum, we can't give this baby this prophylaxis for 6 weeks because we started the ART during labor. So this is a high risk baby. So A obviously is wrong because they have to be on ARVs for 6 weeks. For 12 weeks. So the best is the B, which is where we say once the mother refuses ART, baby should be given ARVs until 7 days after complete breastfeeding cessation. The last one, which is C, when you're HIV exposed, which means you are not infected, but this one it says you have HIV infection.
Okay, I see. So the next poll question is, the following is true concerning a baby whose mother's viral load is greater than 1,000 copies per mil after 12 weeks of infant prophylaxis and still breastfeeding. A, the baby is classified as high risk. B, restart prophylactic ARVs until the mother is suppressed. Restart prophylactic ARVs until after complete cessation of breastfeeding. D, all of the above. So we have about 20 minutes to respond to this question. Sorry, 20 seconds. 20 minutes is the end of the session.
Okay.
No, they're here, man. You can use this one.
Oh, this one. Give me this one.
So the following is true concerning a baby whose mother's viral load is greater than 1,000 copies per mil after 12 weeks of infant prophylaxis and is still breastfeeding. I'll end the poll here and share the results. So that's how we have performed. The answer is D. Dr. Mwiya, would you like to explain to us?
No, for sure. This one, the baby is high risk. A is correct. Restart prophylactic ARVs until the mother is suppressed. This is correct. Restart prophylactic ARVs until after complete cessation of breastfeeding. This is correct. Suppose this baby mother is not suppressed, the next time you do the ARVs, you may have to continue. And it may also be closer to the end of breastfeeding. So this is correct. So all of the above.
Thank you so much. The last polling question. What should be done if 12 weeks old breastfeeding baby comes to the clinic who has not taken prophylactic ARVs? The mother is not yet on ART. Here we're talking a baby who's exposed. So A, initiate lifelong ART in the mother and prophylactic ARVs in the baby and give for 12 weeks. B, initiate lifelong ART in the mother and prophylactic ARVs in the baby. And prophylactic ARVs in the baby, prophylactic ARVs, and give for 6 weeks. there is no need to initiate prophylactic ARVs in this child. Then D, none of the above. So we can respond to this one. What should be done if 12 weeks old breastfeeding baby comes to the clinic who has not given prophylactic ARVs? Mother is not yet on ART. I'll end the poll right here. And here are the results. So the answer is A.
Okay, for sure, this baby again is classified as high risk. Okay, so the best is A, which is initiate lifelong ART in the mother because she's not yet on ART, and then the baby has to go on ARVs for prophylaxis for 12 weeks. Okay, so here, monitoring of the mother to ensure that she suppresses. The rest of the answers are not correct because it says 6 weeks, then one says no need of the prophylactic ARV, which is not true, then none of the above. So the correct answer is A.
Thank you so much. We appreciate the work from Dr. Mwiya, but at this particular time, we now want to hear from the Matero to begin to present their presentation. Matero, are you able to share?
Dr. Mwiya, yes, there's another issue. When we go in these facilities, there's a practice of mixing, using multivit as a solvent instead of clear water when preparing the AZT and 3TC. I wanted to get your comment. I'm sure some of our colleagues are aware that that's what happens.
I've never, actually that has taken me by surprise.
Yeah.
I've never heard of this. I have moved, but
I don't know if anyone else has come across that, but I have.
I'm not sure. I have to consult pharmacy, but I don't know how it dissolves.
I'm not so sure, but that's why I've asked.
I'm not sure about that because as far as I know, it's the dispensable tablet is supposed to be in water.
Water.
Yes, that's how it is made, to be in water.
I think pharmacists would advise that it's called dispensable because it has to be put in water. And so that's why maybe we highly recommend that it's water that is used.
And not any other.
So Matero, could you change your display mode? Go to display settings and change the presenter view. Yes, click on that. So thank you so much. In this particular case, it may be slightly different from the didactic that has been presented. So, but we thought we could learn quite a number of lessons from this case, and so the material will share what they've experienced so far, and we'll be able to learn 1 or 2 lessons from it. Material, could you pick it up?
Good afternoon, everybody.
Good afternoon.
I'm going to present a case from Ngombe. Okay. We're going to look at the history. It's a 2-year-old female diagnosed with HIV on the 13th of November, 2017, initiated on ART and CTX on the 20th of November, 2017.
We'll request for you to just speak a little louder. Not so loud.
Okay. A 2-year-old female diagnosed with HIV on the 13th of November 2017, initiated on ART and CTX on the 20th of November 2018. And this child was 3 months then. The weight on initiation was 3.6, was wasted and weak on enrollment. The mother was HIV positive, but not on ART, used to breastfeed the child the time she was at home, but she no longer lives with the family. She's out on her own. Well, the child was brought to the facility by a 14-year-old sister. The grandmother is too busy at the market. The child defaulted clinic for 5 months from 19th of February 2018. The weight by then was 4.9 kg. The child was also admitted at Levi Mwanawasa Teaching Hospital on the 13th of March 2019, where this child was treated for poor health, PCM, and chronic RTI. Before referral to Levi Mwanawasa Teaching Hospital, the child was given Cristapen and Amoxil at Ingombe. The child had the chest X-ray done on admission at the Levi Mwanawasa Teaching Hospital, which showed TB, and was put on ATT. Then this child was discharged back to Ngombe facility 3 months later. By then, the child had a weight of 5.3 kg. That was on the 23rd of July 2019, and it was not gaining any weight and was failing to thrive. Then the child was referred to UTH on the 23rd of July 2019, but the relatives refused. This child continued coughing, but less, and the weight loss continued, and this time this child was taking ART, CTX, and ATT. On physical examination of the last visit, the child was stable. The temperature was 36, but it was unwell and very weak, malnourished and wasted. The child was also unable to walk. The weight was 7 kg. The chest was clear. The heart sounds were normal. The abdomen was slightly distended, and the child was conscious. The clinical timeline and the laboratory is done. First, the child was on the ART regimen of ABC3TC, Lopinava, boosted with ritonavir, and it was started on the 20th of November 2017. The tests which were done were HIV PCR, which was done on the 13th of November 2017. The result was received the same day, and it was reactive, and ART was initiated. Then viral load was done on the 13th of the 3rd of 2019, and the result was received on the 29th of April 2019. The result was 3,337, and this is what the time the child was being referred to UTH. No CD4 was done, no RPR, no creatinine, no LT, no RPR, no hemoglobin. The questions: how best can this child be managed? Number 2, how can we ensure that this child is getting her drugs correctly and daily, seeing that she's been taken care by another child? Number 3, how can we make use that this child is being fed well with the correct foods?
So thank you so much, Dr. Msonda and the Matero team for this wonderful case. It's a very good case that we can learn from, and I'll just try and summarize it in a few sentences. So what we have here is a female, 2-year-old, HIV positive on treatment, who's failing to thrive and poor social support, and with very obvious missed opportunities in the care of the child. And so at this point, we're going to invite from the spokes, if there are any questions you might want to find out more about this particular child. If there are any specific questions that will help you in managing this child. We've had the 3 questions that have been given. The 3 questions that have been given that they seek your help in. How best can this child be managed? How can we ensure that this child is getting her drugs correctly and daily, seeing that she is being taken care of by another child? how can we make sure that this child is being fed well with the correct foods? So even as we ask the questions for more information, let's have the management questions that have been asked in this particular case. So any questions from the spokes? Material is still around, because you might need to answer some questions that people might be interested to ask. Anybody from the spokes? I'm going to open it up to the hub if there are any questions amongst the experts in the hub. Dr. Thomas.
Yeah. Good afternoon. I just want to ask a few questions. Was there any second PCR done on this child? And then the lopinavir dose, was it at least doubled during the ATT time? And then also just a few documentation like the length of the child or height, any details on the immunization, the under 5 card, and then of course there are a lot of social issues. Is there any other adult caregiver whom we can involve for the care of this child?
Matera, have we heard the questions? Matero?
First of all, I'll start with the last one. The card is nowhere to be seen, and unfortunately, the grandmother who stays with the family is very busy at the market, so unfortunately, there is no other caregiver who can bring this child.
Then do you have any... Please go ahead.
Go ahead. The lopinavir was adjusted, yes, the lopinavir dosage was adjusted. Just repeat the last one for me, please.
One of the questions is about the PCR, if there was a second PCR done.
No, there was no other PCR done. Only one was done.
Okay. All right. So those are some of the questions. So we've got a questions.
UNICEF recommends dispensing the tablets in clean water preferred or breast milk if feasible. At 2 years and weight of 3.6 kg, was the child not admitted for severe malnutrition? I think this is coming from Leonard. And then the other one is, how can we test a 3-year-old baby for RPR?
So those are some of the clarifying questions. Are you able to pick it up, Matero?
Yes. The child was admitted at Levi Mwanawasa Teaching Hospital for 3 months. It was getting treatment for malnutrition, but they couldn't stay long because of the issue of the caregiver. And the RPR was just an oversight. We didn't do it.
I think the concern was that probably they would want you to clarify in this particular case why you'd want to do RPR in a 3-year-old child.
Actually, we didn't do it, and it was not done.
All right. Okay. We get the point. So, and then I just wanted to say something, Dr. Msonda, is that each time you say each, the pediatricians are getting very bothered. They would prefer you say she or he or the child. Okay, yeah. So anyway, so I've seen a hand, Dr. Chungu, you would like to say something?
Yes,
Please
can you hear me?
Yes.
Yes. I would like some clarity on the regimen. And this is something that keeps popping up. You know, we say ABC was on ABC 3TC lopinavir, but were the doses ascertained to be correct? That's one. And then number two, from maybe to Dr. Thomas, we had asked whether they doubled the dose of the lopinavir. Is that the best guidance in terms of TB-ATT interaction, to double the dose of the lopinavir, or are we supposed to go to efavirenz for the period on ATT and then switch back after completion of the ART?
Okay, thank you. So anyway, this child is already on a PI-based regime, so that's why we asked to verify at least if it is doubled. But otherwise, the practice is to put on an NRTI-based regime or the triple nuke. Now again, the challenge with this baby is the viral load is high even before the ATT was started. And then in case if there is PI resistance, we are stuck with no other option because we don't have the second line option to put rotographer, we don't have the pediatric formulation. So I think in the current setup, when they are on ATT, it's better efavirenz based or a triple nuke.
Dr. Chungu, are you okay with that response?
So, Dr. Chungu,
yes,
I think in
Dr.
addition to what Dr. Thomas has said, under the current guidance, we're supposed to go to efavirenz based. Then once they've completed ATT, we go back to lopinavir. But unfortunately, in the next round, this may not happen. And that we can talk. But for now, we go to efavirenz that is still available. Then we go to either the efavirenz or triple nuke. But the triple nuke, the trouble we have is that we don't have standalone, we have AZT3TC, then we have ABC3TC. We don't have a standalone pediatric formulation, which we can use for ABC3TC. Then it's not, I mean, AZT, there's nothing. There's only an adult one.
The quadrenal.
Yeah, so it becomes very difficult to be overdosing on lamivudine. That's a challenge we have. So the only option so far is the efavirenz. And if we can super boost the lopinavir. If not, for those slightly older ones, if they can chew the rotographer, we double dose the rotographer, which is available. We can double dose the rotographer. But it's a chewable tablet, not suitable for this particular child. So for this one, it's just efavirenz.
Yeah,
okay, so I'm seeing that you would like to say something, Dr. Chungu?
Yes, I just wanted to emphasize that, yes, because even when doubling the dose, the serum concentration of the lopinavir was subtherapeutic. So meaning that it's going to even worsen the resistance from the lopinavir. So then important that we emphasize the efavirenz part.
All right, thank you so much, Dr. Chungu. I'll give a chance to Professor Lloyd Mlenga. I've seen your hand raised. Would you like to step in and make a comment?
It's a question to the pediatricians. On Dr. Mwiya, what do you, and the team, what do you think would be the way forward to sort out this, removing the efavirenz?
Sorry, could you just repeat that again?
I mean, what would be the way forward on what the if there were no limitations with the drugs which we have available, what would the pediatricians be comfortable with?
Okay, so what to be comfortable with? First of all, if we had ability to do triple nuke, that would be fine as a way forward, because the NNRTI is like with the current recommendation, we're not going to use in pediatrics, so there will be no efavirenz. They only been developing because of the prophylaxis, but for treatment, no. So the way forward is we can do triple nuke, and then we can also do rotographer double dose if we had the means. or the suitable formulations. And then also if we can boost propinavir.
Yes, actually.
Would you use something like Difabutine?
Yeah, if you had Difabutine, that would be fine. But again, it's the age limit. I think there's an age limit to what you can use in pediatrics.
Okay, thank you so much. There's been a lot of discussion. So Sorry, I still want us to drive us to responding to the particular concerns for this particular case. So, Professor Lord, you can go ahead.
No, I think we can discuss during the guidelines meeting.
Oh, all right. Okay, thank you.
Okay.
So I would like to get now comments on how we can manage this child. We've gotten a few questions, a few clarifications here and there, but now can we now respond to this question? If you've got people, experts on the spoke, go ahead. We've got experts in here. Can we hear before Dr. Mwiya comes in? Anything? Dr. Mpeta, Dr. Sivile, Dr. Thomas? Okay, so I'll allow Dr. Mwiya to give some recommendations for considerations for this case.
Okay, so the first thing anyway on this child, it appears a lot of social problems. This is the biggest challenge we have because she's being looked after by another child. So if there was a way in which we could find someone who's more reliable, if that fails, are there any social groups or support groups which can help this child? If that completely fails, can we take this child to an orphanage? That's the worst that can happen. There are a lot of houses or homes where the child can be looked after properly. That way, then we ensure that this child is cared for in terms of nutrition as well as the ART. Otherwise, the biggest challenge is here is social support, that this child is not being looked after properly. So coming to ATT, it's only in the next 3 days this is supposed to complete treatment.
Yeah.
So we can give the ATT the way it is until we finish. By that point, we should do an X-ray to check whether the TT has been completed, it's cleared or not. Okay? But it comes to ARVs, I think we'll leave the lopinavir ABC 3TC the way it is, but we need to do a viral load, and then we will also need to do genotyping, because this child has been given sub-therapeutic doses, okay, because of poor adherence. So we need to do viral load, and we can do also genotyping, just to make sure that there is no resistance. But my fear is that sometimes if the child was not being given properly, that's one. Added on TB, we may still find the wild virus type of, the wild type virus. So again, they may not show any resistance. So the best maybe we can do now, and then 3 months down the line, once adherence has been assured, we repeat and then do a genotyping to see once we have added pressure to the virus. Okay. The last one again is to make sure we take care of nutrition. But in terms of nutrition and the giving of medication, we need to find some support of some kind, either with some reliable relatives or taking to an orphanage, or some home where there is going to be proper care for this child.
So thank you so much. If there's a comment.
I think it's also better to do the ALT, a full blood count, and creatinine, since there was nothing done at baseline, and this child is so malnourished, and on ATT, ARVs, I think it's a better thing to do all those things.
So thank you so much, Dr. Thomas, for that. I think I also observed it, that I think those are some of the basic things that we could have been, at least we could have done even before presenting the case.
And CD4.
And the CD4. Thank you so much. We have a comment from the spoke, Dr. Chungu.
Yes, I just wanted to agree with all the comments with Dr. Thomas, with Dr. Mwiya, but just to underscore, and thank you, Matero, for a very good case, just to underscore that when it comes to issues of adherence, I think the best solution is the environment itself. You need to sit down with or caregivers around, because yes, the solutions that are being given here are it's guidance, but the real solution will come from looking at this child's environment. What type of support is there in the immediate environment? Because if we can't get assurances that this child was taking the ARVs, how do we have assurances that they were taking the ATT as well? So meaning that, you know, you really need to look at adherence. I think a lot of studies have demonstrated that when children had high viral loads, it was an adherence issue up to 70%. I think even at PCOE, when they looked at all those kids that were sent for lopinavir, failing on lopinavir, most of them, it turned out to be adherence issues. That's right, Dr. Thomas, isn't it? So meaning that you really need to sit down with your whole team, the family, the extended family, sit down and look at what is the best solution. And those answers will be generated from within that community with the support around. And that's how the best support that can really benefit this child.
Thank you so much, Dr. Chungu. What I get is that the sense I get is that we really need to break the barriers from the way we are trying to this child in which the child is being managed. We really need to go deeper in terms of checking the child's environment. Are there any other comments?
Just one more thing. We heard there's a grandmother who is busy in the market. So maybe what we do in such situation is we will call them, talk to them, find a convenient time before they go to the market to give the morning dose, and then we usually advise them to knock off a bit early for the sake of the child to give the evening dose. That is what we do in our setup. So we should really talk to the grandmother, because that's the only other option now, since the other girl is only 14-year-old. We can't assume that she is going to give it. So the grandmother needs to be engaged into and adjust her time for the market, I think.
Thank you so much, Dr. Thomas. Professor Lloyd, I see your hand is up. Would you like to make a comment?
Yeah, I think for me, I would just like to emphasize that we need to do genotyping now.
Okay.
When you look at this viral load, a viral load of less than 10,000 in someone whom we are questioning adherence and someone who had defaulted likely indicates that what you are dealing with is a resistant virus. It's not that maybe this child has a wild virus and the patient has been off. So this is likely to be a drug-resistant virus. And I think the lopinavir is still active. If lopinavir was not active, the viral loads would have been much, much higher, above 20,000 or so. But 3TC likely is gone and ABC may be gone. I think we need urgently, before changing any ARVs, you need to do the genotyping.
No, thank you so much for that guidance, Dr. Professor Lloyd. I had a question as well, just regarding the management of this patient. Where are we going to manage this patient from? At what stage do we say this child requires expert management? At what point do we say will remain in the facility in the way it is?
So the way it is, Dr. Jambo, is very complicated. So you need to co-manage. Okay. Because one, if we say you want to send them to us, then you have issues of transport, they want, and then financial constraints. So that's a limitation.
Okay.
So you need to co-manage. Either you get a sample, send it over for genotyping to us, and then we keep discussing. And then you also have to discuss on how best to manage their nutrition. Otherwise, it will be challenging for the patient. Okay. We can co-manage. I think it's easier, like when we discuss on how best to handle the child, to help them as well.
All right.
Yeah.
Okay. This has been a great discussion and a great topic. Thank you so much, Matero, for bringing it up. And so I would like to just consider that we may consider what has been discussed. I'll try and summarize it for this particular case. And so we have a child who's a 2-year-old female on ARVs and failing to thrive with a very poor social support and had some missed opportunities. in managing. So what has been recommended so far is that we need to look at it twofold. We look at the social aspect and the medical aspect of it. In the social aspect, we need to address the adherence issues and how can we solidify the adherence issues. So we need to consider engaging extensively the families unless we really fail so much in that. We may have to consider putting the child in an orphanage, which is not the best, but it may leave us with no choice but to do something like that. But let's engage way of doing things to ensure that we engage with the relatives on this one. Then that once we address those issues, we will be able to address the nutrition issues as well, I'm sure. Then in terms of medical management, it's been advised that we may continue with the current drugs since the TB they'll be finishing the TB therapy very soon. But for future events, it's important to follow the guidelines that we may either move to efavirenz or the triple nukes, meaning we have AZT, 3TC, and ABC. And so in terms of monitoring, we will need to do genotyping and viral load monitoring for this patient. So I don't know which one will come first, but we'll need to do viral load. We take the viral load, and then we do the genotyping. So all those are the management consideration for this particular case. And
Doctor, so sorry, doctor.
Yes, sir.
Why don't you at the same time you pick?
So your network is a bit difficult, so we haven't heard what you've said.
Load, send it to the genotyping lab because the viral load will be done and genotyping only proceed afterwards.
What do you think? The viral load, they'll do the genotyping.
Okay.
They find it's high.
Okay.
Yeah, same time.
All right. All right. No, we've taken note of that. Thank you so much, Professor Lloyd. I just wanted to have one more comment from Davis Kampamba.
Judith, have you understood those recommendations? Dr. Mwansa, Judith?
I've written them, yes.
Yes, we have. Okay.
I've written them.
All right. Thank you so much. Davis, are you around?
Yes, Kozia.
Yes. Could you give us a comment on the use of Multivit and dispensable tablets?
Okay. So I know that sometimes is a common practice with...
Oh, could you please speak up?
You can't hear.
I'm saying that is a common practice, especially with some of these drugs. But where AZT3TC is concerned, that has not been proved, so we cannot assure stability. And just in case there is some interaction with AZT3TC and the Multivit,
okay, so we take it.
Yeah, I just wanted to emphasize that. Davis is speaking.
Davis, are you still making a comment? We can't hear you.
Okay, the last point is once the suspension...
Your mic is very far from you.
Okay, I'm saying once the suspension has been made, even with clear water, patients should or caregivers should always be reminded to use it within 10 to 14 days and not beyond that.
It works before 10 days.
Okay.
It works.
Yep.
Davis, are you still on?
I'm still
all right,
on, but I'm done with my comment. Thank you.
All right, thank you so much. Dr. Sibile, you had a comment?
Yes, I think it's just an emphasis that lopinavir, ritonavir should be doubled like the way they've done. If it was even, if you were able to boost, it should be done. Yes, I know there's 3 days left with an ATT, but the effect for enzyme reduction persists after you stop the drugs.
Okay.
Over about 2 weeks, 3 weeks, because these are enzymes that proliferate. So you can stop the TB treatment today. That of degradation of the drugs will persist for some time. So please, let's up the dose, like Prof has said. Likely that there's some minor resistance to this ritonavir. If we lift up the dose, this patient likely will resuppress with that viral load of 3,000. So I think that's a big recommendation.
So this is April 1.
So yeah, I think it's just that we should make sure that we give the correct changes now, even if we are about to.
All right. So thank you so much, Dr. Sivile. Thank you so much to the presenters from Matero, and thank you so much to Dr. Mwiya. Thank you so much to the experts, and then we also continue to thank the spokes for participating in this session. Thank you so much. And so this has been a very fruitful and helpful presentation that we will have. And so I'm going to ask Dr. Sombo to give us our the next topic of discussion.
I think it's basically recency testing.
Okay, so we'll come and learn what recency testing is all about next week. So let's please plug in and get to participate. Otherwise, thank you so much and have a good day. Thank you so much.